everybody. It's almost afternoon, at least for part of us. Other people are already well into their afternoon on a Saturday. We are waiting a few minutes to get started with our afternoon presentations, but I did want to remind everybody we've got a lot going on today. So not only is there some great content by the speakers, if you're in the platform, there's a thing on the left that says surveys. You can click on that or scan the QR codes that pop up during breaks to take some surveys and really help us get an idea of what patients are looking for when it comes to non-clear cell or in neoadjuvant therapy. We also at 3:30 Central Time, after all of the lectures are over, we'll be having a focus group for those patients with the differing types of non-clear cell renal cell carcinoma. So again, if you go to the programs page, it'll have information about that Zoom. We encourage you guys to join us where we're just having an open discussion about how we can meet those needs for those patients. Also, just thinking about KCA in general, we've gotten some great questions through the chat, but if you do have specific things for the KCA, you can always fill out the evaluation at the end. You can send suggestions through the chat. You could email us through the different things on our website. Bottom line, we are definitely here to help you guys and give you guys what you need. So do not hesitate to reach out. Our next set of presenters are actually going to be talking about the reason to maybe seek a specialist or go for a second opinion and how that's helpful in kidney cancer. And so we have, how technical difficulties are 2 years into Zoom, and we're still sort of, everybody always says internet issues, no matter what we wait for here, at least it's not dial up. So we are waiting for that. But basically, our first presenter is actually going to be Dr. Christopher Waite, who is the Center Director of Urologic Oncology at the Cleveland Clinic. And he's going to start off with why it's important and to seek that second opinion. And then we're going to talk about an initiative that we're partnering with in terms of how to get that virtual second opinion, which I believe some speakers mentioned earlier. So Chris has just popped in. And I'm going to share the slides here. There we go. All right. So Dr. Waite, hello.
Hello, how are you?
Good. Sorry about the difficulties you're having today. I am just going to switch it over to you and block myself out and just tell me next slide when you want to go forward.
Great. Well, thank you very much for this opportunity to speak to you. I'm really excited for this chance, and the KCA has been a strong supporter of kidney cancer, and that's important to me. So I'm excited to talk tonight, or this afternoon, I guess, about why kidney cancer specialists and second opinions may be worth all the fuss. Next slide. I have no disclosures with respect to this topic. So I really want to focus on kind of 4 areas, and Peter Rasmussen from Cleveland Clinic will be joining me in this discussion. But the first one is why a specialist in kidney cancer? The next topic is how to find one. The next is how does a second opinion help? And then finally, what are some of the drawbacks of a second opinion? So why do you need a specialist focused on kidney cancer? And let's talk about that. Let's go to the next slide. This is a study that we did a few years ago, and this kind of illustrates really well, I think, why it's important to have a specialist. This was a survey that we did of surgeons in North America, members of the American Urologic Association meeting, and we sent them a survey and we sent them pictures of kidney tumors, like you can see the one on the left of the screen here. And we had a variety of different kidney tumors, different patient scenarios, and we asked the surgeons, what would you recommend to a patient? And what we found was really interesting, and one that there was a huge variation in what was recommended to a patient. And that may come as a surprise. If you're going to see a doctor, you may think all doctors are going to say the same thing. But actually, there's a lot of variability in how patients see kidney tumors. And this was particularly focused on whether a kidney could be spared or whether the whole kidney had to be removed. And what this graph is showing is we grouped surgeons into 3 groups of surgeons. Group 1 was a kind of older surgeon who did not do a fellowship and practiced in private practice. Group 3 was a younger fellowship-trained surgeon who practiced in an academic setting. And then Group 2 was kind of in between that, kind of middle-aged, not fellowship-trained, but practiced in a larger practice. And what this shows is a graph on the x-axis of increasing tumor complexity. So going from a score of 3 up to a score of 12 being the most complex tumors. And then on the y-axis, it was the probability of offering a partial nephrectomy versus a radical nephrectomy. So as you might expect, as the tumors get more complex, the surgeons in general are more likely to say, well, maybe the whole kidney should come out as the tumors get larger and more central. But the thing that's really interesting is there were 3 distinct patterns to this. And if you look at the complexity score on the x-axis, the surgeon group 1, again, these are kind of older surgeons, don't see a lot of patients with kidney tumors in a year, not fellowship trained, not in a big specialty practice. Their inflection point was right around a complexity score of 7. And that's kind of on the inflection between low complexity and moderate complexity, where more than half the surgeons with tumors more complex than that would say, okay, now the whole kidney needs to come out. But in group 2, that inflection point didn't happen until a tumor complexity of score of 9. And in group 3, that inflection point really didn't even happen, even in the most complicated tumors. And so it's a really good illustration that if you showed up to a surgeon in group 1, they very, and you had a tumor that was on a complexity score of 8, they very well say, you need to have your whole kidney come out. Whereas if you went to a surgeon in group 2 or group 3, they would say, oh yes, we think with a high degree of confidence, we could spare this kidney. So a really good sort of concrete example of how a second opinion, someone who specializes, has additional training in kidney cancer, and sees a high volume, might see your tumor differently and might give you different options that may be very important for you to know about. Next slide, please. So this is another quick example from that same study. This is also how surgeons see things differently. So this was all surgeons kind of clumped together, and these 2 tumors are exactly the same size. And tumor A, 97% of the surgeons we surveyed said that they would do a partial nephrectomy, but in tumor C, only 45%. So even though they're the same size tumor, more than half wanted to take out the whole kidney in tumor C, but 97% would spare that kidney in tumor A. And again, that is influenced by your surgeon's experience and their expertise, particularly in kidney cancer. Next slide. So now you understand that you might get different options and you might be told that there are different treatments available. That's one reason to see a kidney specialist. The other is a well-established volume outcome relationship. This is well-established in many different kinds of surgery, but here is a landmark paper that came out almost 20 years ago now that's showing if you divide surgeons into 3 groups, kind of low volume, intermediate volume, and high volume surgeons, you see that there is a corresponding decrease in complications. So the lower volume surgeons on average have higher rates of complications than intermediate or high volume surgeons. Next slide. So you can see this happens in a wide array of surgery types, and this is including nephrectomy. There's been a noticeable difference in surgeon volume. Next slide. But there's also a noticeable difference in hospital volume. So it kind of makes sense. If you have a surgeon that does this a lot, they probably will get better at it. Their team will get better at it, and the outcomes may be better. But what was really surprising to see is that there was also a relationship between the hospital. And so a hospital that has a high volume, independent of the surgeon, also has associated better outcomes with better survival and lower complications. And the thought process is that not only does the surgeon play an important role in your outcome, but so does the entire team, the anesthesia team, the nursing team, the circulating nurse, the preoperative and postoperative nursing team. So it's a team effort to get patients through surgery in particular, and an added reason to go to a kidney cancer expert who has a lot of not only volume and experience, but also works with a team that has a large volume and experience. Next slide. Well, and so we've talked about now you are more likely to get a wider array of options. When you see a kidney cancer expert, you're more likely to have better outcomes if you see a high volume kidney cancer expert who works in a high volume hospital setting. And what about more information? Well, this was an interesting study done only a few years ago, and they found out that second opinions get patients a lot more information. So one is often when you get a second opinion, the second opinion team will have their pathologists and radiologists reevaluate. And again, at high volume referral centers, these pathologists and radiologists are seeing a high level of kidney cancer. And so they maybe are starting to pull out some of the subtleties, and the diagnosis gets changed about 15 to 20% of the time when these biopsies and exams are reevaluated. Treatment recommendation changes happen at about 30% of the time. Therefore, if you get a second opinion, about half the time there's going to be a slight difference of opinion, at least from the original recommendation that was given. And when you survey patients who have gone on to get a second opinion, about 90 to 95% report that they were being happy that they got a second opinion. And sometimes you just get a reconfirmation that the option you heard in the first place was a good option, and you feel a little bit more confidence that you did your homework and this is the way you want to go. Next slide. So again, in summary, why get a kidney cancer specialist? Well, you're likely to get new information. You're likely to understand more about your disease and about the options available to you. You'll be offered a broader array of options, and you may have better outcomes as those high volume outcome show. Next slide. So now a more practical question, how do you find one? Well, the great thing is a lot of this information is available on the internet. Some of the details I mentioned to you before can be derived from looking on the internet. There are also some really great patient forums available online and social media and other places. But it's good to look for someone who is fellowship trained, who has done some additional training in cancer in particular, or who are publishing in kidney cancer. So you can look up, there's an online research tool called PubMed that you can search their name and find out if they've had publications, because often if a physician has published on kidney cancer, they're really thinking deeply about it. You can get information on high volume hospitals. You can assure that the practitioner is a national cancer, works at a National Cancer Institute designated cancer center. There are, I believe, 30 to 40 of these across the United States, and these are designations where you have multidisciplinary cancer care. And finally, if you go to clinicaltrials.gov, you can search for clinical trials on kidney cancer, and you may find the leaders of these clinical trials tend to have a lot of expertise in kidney cancer. Next slide. Here's just a map showing all of the NCI designated cancer centers across the United States. So most places in the United States are not too far away from one, unless you live in the upper Mountain West. As you can see, there's not a lot of people live there. So most people in the United States live fairly close to an NCI designated cancer center. Next slide. So, nothing's perfect, and there are some drawbacks. Some often for a second opinion, you may have to travel a significant distance, and that can be costly and a headache. And I know at Cleveland Clinic, it's quite a large center. So we have a lot of people coming from small towns in the surrounding area, and it can be a little bit intimidating to drive up to a really big center like that. Occasionally, they're not covered by insurance. Often they are, but sometimes they're not. And that's something you should check in with your insurance company. And if not, it's something that is a good idea to petition for. And you can use some of the data that I shared earlier, that 50% of the time, either the diagnosis or the options are offered or different. And that can be a strong arguing point for your insurance company to pay for it. One other drawback is, you may leave a little bit confused if you get a very different opinion from the first opinion you got. You may be left wondering, well, who should I believe? And that can be sometimes frustrating, and that's particularly challenging if there are several standard options that are thought to be acceptable. So sometimes you're going to have to filter through all that information to make the choice that makes the most sense to you. And then you may get a recommendation that's just the same as the original one you got, and you may feel like, well, that was a waste of time and effort. But many other patients feel like, okay, now I know this is the thing that sounds the right, and this is now given me the fortitude to move forward in this new course of treatment that you've chosen. Next slide. And that's all I've got. I think I don't know if Peter's going to go right next, or I'm certainly happy to take questions either now or at the end of Peter's discussion.
Sure. Thank you very much, Dr. Waite. I do want to give you a couple questions before we move on to the next section. One of the things you mentioned is that sometimes it can be conflicting from what the first physician sort of gave you. Do you have any recommendations on, if the patient seeks that second opinion themselves, how to bring up the conversation to not offend their doctor, or open that line of communication about a possible difference in whether it be diagnosis or treatment?
Yeah, I would say two things. One is that I know it feels, you almost feel in some ways like you might be betraying one of your doctors or letting them down. But I would say I give second opinions all the time, and my patients get second opinions all the time. I never take any offense at that, and I think most physicians don't. So I wouldn't feel bad about it or embarrassed about it. I think it's a logical thing to do, and I think it shows a patient who's engaged in their healthcare. And so I actually like to see that effort, because it tells me that this patient is going to be an active participant in their health. On the other hand, when you do want to bring it up and discuss and talk through, now I've got two different opinions, help me understand why I'm hearing two different things. I think that's an easy way to say it. You say, listen, I am trying to get the best option for my cancer care, and I've gone to two people who I very much respect and admire, and I'm hearing different things. Can you please help me understand why I'm getting differences of opinion, and what are some of the pros and the cons, and why these recommendations are different? And I think most physicians will respond really well to that kind of approach. And if they don't, that might be a little bit of a clue that maybe that's not a clinician that you want to continue care with, because if they're a sort of a jealous sort of clinician, that they may have some personal challenges that might get in the way of your care.
Great. One other question for you, not necessarily specific to kidney cancer, but could be. Are there specific patients who you think would benefit more from a second opinion than others, like rarer subtypes, or a specific gender or age or other medical condition that might be worthwhile to seek out that second opinion?
Yes, I think there are probably three categories where I think there's a really good idea. One is kind of the rarer subtype. If ever you hear your physician say, well, I've never seen this before, that's not unusual. That happens to all of us, because that's one of the things that's so interesting about medicine and cancer in particular. But that might be a clue that they may be operating on the edge of their knowledge, and you might want to seek another opinion in that scenario. Another common scenario we see in the surgical area, and this is less dealing with the chemotherapy, systemic therapy, immunotherapy, but if you are told your whole kidney has to come out, I think that's one where we see a huge amount of discrepancy, that if you go to a higher volume surgeon, we see many times where they've been told they have to have their whole kidney out, and then you go to a high volume surgeon, they say, no, this is completely, we can spare this kidney and get the tumor out. And then another thing I would point out is also a very small kidney mass. If you get diagnosed with a small tumor that's about 1 inch or 2 in size, many of these can be watched safely. And I think we're trying to get this message out, but it's still, we're having a hard time getting that out. And then we see in lower volume surgeons, they're just recommending removal. And anytime anybody hears you've got cancer and everybody says, okay, get it out of me. But it turns out many of these tumors aren't cancer in the first place, or they're very low grade tumors that can be safely watched. So that's the other scenario. Very small kidney mass usually can be safely watched. And if you're told it has to come out, maybe a good idea to get another opinion.
Yeah, it's great that you bring that up. I used to work in the thyroid cancer space, and that was a big transition for them as well, in terms of many of the ones removed did turn out to be benign or not as serious as the concern was. And surgery is actually riskier, or those side effects of surgery. So that's definitely a transition that's happening in the kidney cancer space. And I did lie. There is one more question.
Okay.
You talked about like these bigger centers, and a lot of those tend to be academic centers. Patients have some concern, although that might be where a lot of the experts are, like an MD Anderson or an academic institution, but that's also where you have a lot of students. And so how can you ensure, if you're going to go to one of those centers, that you're not getting somebody, although you've gone to them because they're a high volume center, is being done by a new resident, or being, what's that fear the patients, have with that, and how can they get over that or figure that out?
Yeah, that's a great question. I think the really interesting thing about that is, one, first understanding what the data tells us. And the data tells us that almost uniformly, on average, academic medical centers have better outcomes on average than non-academic medical centers. And that may seem paradoxical, because I've heard a lot of patients come and say, I don't want someone learning on me. And my answer to that always is, I'm continually learning myself. And even though I've been doing this for 20 years, I'm still continuing to learn. But the second point is, I think you actually want multiple heads thinking about how to take care of you, having your staff surgeon taking care of you, but also a resident, an intern, and a medical student. To have 4 or 5 people thinking of you, it helps so things don't get missed. It helps to, that you really get good care. And then finally, I would say, I would express those concerns directly to your physician too. Just say, listen, this is a concern that I have. Help me feel reassured. And I think you can establish, which portions of what it is that makes you scared, and that your surgeon will have an opportunity to talk through how things go. We are in there, and most often we're doing the critical portions, or if not, under very close supervision in a very sort of progressive transfer of learning. And like I said, the data really seems to bear out that model actually gives the average patient a better outcome than a worse outcome.
Great. All right. So I want to make sure we have enough time for the next presenter, but if you are able to, and we'd love you to stay on in case any other questions pop up during the second part of the presentation. Otherwise, hopefully Frank will take care of it for you. But we do have our next presenter. It was going to be Dr. Peter Rasmussen. But one great thing is doctors need to take care of their patients, and he got called into a surgery. So that is what he is doing for us right now. But luckily, we have the CEO of the clinic by Cleveland Clinic, I'm not sure if it's doctor or not, I assume it is Dr. Frank McGillen, who's going to be talking about an actual virtual second opinion service that the KCA is very excited that we'll be partnering with on, giving some discounts to our KCA community. And so be looking for that launch in June. But I want to turn this over to Frank to sort of take us through what the service is that you guys have.
Thank you, Sally. And not a doctor, but I play one on TV. At least today, I'm trying to fill in for Dr. Rasmussen, who would have loved to have been here today, but had a complex case, emergency case, and obviously puts patient care first. But today I want to talk about the virtual second opinion program we have at the clinic for Cleveland Clinic. And just a bit of background, the clinic by Cleveland Clinic, it's a joint venture between Cleveland Clinic as a majority shareholder and Amwell. And Amwell is a leader in telehealth technology. And really the formation, our vision is really how to make it easier to unlock the access to the best care. And the way we're doing that today is through our virtual second opinion program. So I'll talk a little bit about the program and some of the benefits and how you would access a virtual second opinion, and also answer questions at the end. So next slide, please. I think Dr. Waite hopefully gave an overview of the top rated kidney program at Cleveland Clinic, but the Glickman Urological and Kidney Institute's #2 program globally, and I think really brings a level of expertise that's so important when dealing with a complex condition, also offers innovative solutions, minimally invasive, new procedures, and I think as Dr. Waite mentioned, the ability to really take a more, I think, a more informed and nuanced approach to managing complex disease, which obviously is so important. I think the other thing, and it really gets back to sort of the Cleveland Clinic mindset and mentality. I think first off, Cleveland Clinic physicians are all staff physicians. So what does that mean? Cleveland Clinic physicians earn a salary. So they're always, they're, as opposed to having any financial incentive to go in one treatment path versus another path. And it really, from a mindset, it really gets the focus is back on the patient. What's the right thing to do for the patient in terms of helping folks get the best care needed? The second thing is a very multidisciplinary approach. Medicine is a team sport. And as we're looking particularly in the second opinion space, there's a lot of collaboration between the clinicians at Glickman, but also at the Taussig Cancer Institute, bringing in specialized radiology, specialized pathology to make sure it's a 360-degree view of the case. And we're tapping into the knowledge and the wisdom of the larger team. Next slide, please. So what is a virtual second opinion? Well, it really is all about getting direct access to the right expert physician to get the peace of mind you're going the right direction when dealing with a complex medical condition. So it all starts from an intake video conference or video with a nurse, and that could be on a smartphone, could be on your laptop. So what we're doing is able to basically provide that access without travel, without need to take time off from work or some of the complexity and hassles of a traditional second opinion visit. So it starts with an intake with our nurses, and our nurses are really focused on helping understand what was the diagnosis you had received, who have you spoken to, what options were given to you, your medical history, and getting really a good solid background to help inform the right approach forward. From there, and it's typically about a half-hour conversation, sometimes a little more, sometimes a little less, depending on the condition. From that point on, the nurse case manager really is the advocate for the patient to really help ensure they're getting that access to the right expertise. We take a very concierge approach. So from that point, we take control and start, gathering all of your records, reaching out to your current physician, making sure that we're getting your patient records, your any imaging, any pathology, et cetera, and pulling that all together to make sure that we can help get to the bottom of your condition. There is radiology and pathology reinterpretation for every cancer case we see. So we want to make sure something wasn't missed. And we've had examples. There was recently a breast cancer case that we helped a patient with where there was some complexity to the cancer that was missed by the original radiologist. And Cleveland Clinic uses specialized pathology. That case was radiology, but uses specialized pathologists and radiologists who really focus deeply in that organ or that disease state. Once the reinterpretation is concluded, there's expert matching. And, it really is all about trying to find the right specialist for your condition. So, a urologist may not be good enough, particularly if there's complications or if there's some very specific situations. So we make sure we're finding the right specialist and help curate that decision for you, because getting to the right expert is so important. We try, if there's a request to speak to a certain physician, we try to accommodate that request. Not always possible. And sometimes, a patient may think, Dr. X is really the right match, where again, they're based on their medical history, based on the diagnosis, based on the records we've looked at. There's someone who's much more appropriate that may not come up on an initial Google search. Once that expert matching is provided, we're providing all the case files, imaging, case history, et cetera, to that expert physician. They do a thorough review of all the information, and we schedule a video consult between the patient and the physician. And that's a chance for the physician to basically explain their recommendation, what their analysis is of the situation. if there's a recommend in terms of a change in treatment pathway, if there's an alteration in diagnosis. So we really try to make it a very seamless, easy effort. Total process here, in average, takes about 12 days. And really the longest part of that is gaining the medical records from the other institution. If the hospital is using Epic, we can pretty much get the records instantaneously. Unfortunately, in the world of medicine, interoperability isn't here. So, there's still faxes going back and forth and CD-ROMs, et cetera. But, our folks are expert at getting that information, and we try to shorten that because we know, when you're dealing with a serious diagnosis, just how important it is to get answers quickly, but we want to make sure you're getting the correct answer. Dr. Wade had mentioned some research that was done that was showing that the value of a second opinion in terms of changes. We find about 78% of time, based on analysis of second opinions we've done over the past 2 years, that there is a change in the care pathway. And about 25% of the time, there's actually an alteration in the diagnosis. So, we find that it adds a lot of value. And even for people folks who go through a second opinion, even if there's no change in diagnosis, there's a high degree of confidence and I think reassurance that you're going down the right pathway. And you don't have to second guess. You can just focus on taking care of your health and managing your health moving forward. Next slide, please. In terms of the patient experience, and we really, again, try to cater to the patient. It's all about helping folks who are dealing with complex medical conditions like kidney cancer. What we hear from people who've gone through the program, and here's a few direct quotes, relieved, deeply grateful for the team making this invaluable service available, confidence, this brought me peace of mind as I proceed, and really empowered to move forward. We take that experience very seriously. Each and every interaction, we ask for feedback along the way. Our nurse caregivers, get on average a 4.9 stars out of 5 based on how they're managing that case from end to end. We find that 93% of patients who participate in the program will implement their expert physician recommendation. About 90% of the time, they're satisfied with the speed of turnaround and a high degree of likelihood to recommend their expert physician to others. I want to build on a point that was actually raised earlier about, academic medical centers and experts, dealing with, medical students or residents. And, at least in our program, you're always assigned to a expert physician. In many cases, it's some of the most senior folks within the institutes who participate in rendering the second opinions. So that's I think that's the last slide. I think one final point. I will make is this service, as it's a global service. This is not typically covered by insurance. We do, there are some health plans that we partner with that offer the second opinion as part of their premium benefit offering. Typical cost is $1,850 for the process. We're handling everything from end to end. We will be announcing a partnership with the Kidney Cancer Foundation. We're trying to make it more accessible. And I really appreciate the opportunity to be here and can answer any questions folks may have.
Yes, thank you so much. And Frank, if Taylor Swift can get her honorary doctorate, we'll give you an honorary doctorate today with that. So again, thank you so much for filling in for Dr. Rasmussen. We do have a couple of questions, and I'm not sure, it might be more appropriate for Dr. Waite to answer as well. But you sort of touched on the fact that this service in particular isn't necessarily covered by insurance. And I think a lot of that comes from the fact that for doctors, they have to be credentialed in the states that the patients live in, that they're giving those opinions to. But, so it's not something they're necessarily going to seek in this instance, but you are still getting, it's not necessarily, some Joe Schmo off the street. You're getting a valid medical review by a specialist from the Cleveland Clinic when you're doing this service, even though it's not something that would necessarily be submitted to insurance, correct?
Yeah. Let me comment, and Dr. Wade, if you have any additional points to make, is that, first off, the service is offered nationally, so we're eliminating, the need to travel, et cetera. To do a face-to-face, and I'm sorry, let me take a step back. It's available nationally. It's actually, we provide our second opinion service to folks in, I think it was the last count, about 50 countries around the globe. Our second opinions are considered an educational consult. We don't take over we don't establish a patient-physician relationship during the second opinion process. And that's why it's considered educational, and licensure is not an obstacle. And this is true with any professional second opinion program. So we make it easy to access no matter where you're located. But the fact that it's educational, does it not impact the quality? Because you are getting access to some of the best specialists in the globe who are, again, reviewing your case in a very comprehensive way, taking a fresh look at your case and that entire history, and providing you the best expertise that they can provide. So, that's, our operational model. Chris, I don't know if you have anything to add.
Not a lot. I would just say that I've participated in several of these consults, and I think that that they do tend to be a great opportunity to really kind of fine tune your questions. You have an expert focused on your case, having had the pathology and the radiology reviewed ahead of time. So I think it's a very quick way to get a high level of expertise on your case right away, and help you feel confidence to move forward on the care pathway.
Great. Thank you very much. And again, KCA is going to be working to try and get some additional discounts for patients in terms of using this service. So again, stay tuned for the launch of that in June. Another question came in that for these second opinions, knowing that various physicians, speak on behalf of drug companies, or they're on the advisory boards for drug companies, do you recommend that they plug these names of whoever's going to see them into some type, whether it's through this service or otherwise, into like the CMS open payments or ProPublica dollars for docs to understand their conflicts of interest? Doctors should be practicing without that influencing them, but is that something patients need to be concerned about?
I can take a crack at that one. I would say that I think it's always a good idea to do due diligence. I think one of the hardest things to do when you're first diagnosed with cancer, especially if you've never had any serious disease or any interaction with the healthcare system, is learning how to be an engaged and informed and active participating patient. I think there's often this model is that you go in and the doctor tells you what to do and then you do it. But I think that's not the model that works the best. The best model is that you do some of your research on the side, you investigate what you can understand on the resources that you have available. I would say if you go online, stay on .gov or .org or .edu charts, stay away from or websites, and stay away from .com websites. But you do the best you can to get the information and put it into context, talk to friends that you have. And I think looking up physicians and looking for their conflicts of interest is totally a legitimate way to help you understand and put into context the recommendations that may be coming your way, so you can find the route that works best for you.
Yeah, I would echo everything Dr. Wade said. I think it's best for patients to be their own advocate, and and researching and getting information about the physician would just be part of that.
Yep. And one of the things I would caution though for patients too is a lot of doctors sit, especially the experts, sit on these advisory boards, work on these companies with studies and so forth. And that only helps sometimes add to their expertise because they deal with that data a lot more. They're not just reading a summary paper that comes out. So sometimes those connections to industry can be helpful, but absolutely do your research. I know sometimes we have people to check health grades and things like that for how good the physician is. know most people when they give reviews tend to complain. That's what a lot of these sites do. So, take that with a little bit of a grain of salt, as well as the fact that sometimes the physicians that have the best skills sometimes aren't the best relayers, with patients. And so you have to sort of balance that a little bit. You have to find what works for you. It's trial and error. One of the other questions that came up, and this would probably be better for Frank, is you mentioned that once the 12 days have gone by on average and you have that consult with the patient, do you guys have the availability to do the consult with the doctor in case the patient's intimidated about relaying that second opinion information to their doctor?
Yeah, that does happen on occasions. I mean, typically it's just with the patient and the physician. Particularly fine when we're helping folks overseas, that the physician is almost always involved outside the U.S. But we find, at least in our experience, is to have that kind of one-on-one with the Cleveland Clinic expert and the patient works best. And the fact that they don't have to worry about what questions they're asking, it can be a very open dialogue. And we do provide a written report to the patient afterwards. And we will handle, follow-up questions after the initial consult.
Sure. And do you ever recommend that consultation be done, say, just on pathology reports and send to a pathology specialist? Or should these people be seeking out something that's going to be more robust? I'd love to hear both standpoints where you're getting, radiology plus the pathology plus some clinical review.
Yeah, I'll give at least our perspective is it's best to have a 360-degree review of the case if you're looking for a second opinion. It's a complex condition because it's not, if you case of pathology, that's only one part of the overall diagnosis, and it's only one part of it, of potentially a treatment plan. So we always think the more comprehensive approach makes sense. I'm sure there are some areas where secondary pathology, and I know Cleveland Clinic Pathology does a lot of second reads on pathology, but I'd love to hear Dr. Waite's perspective as well.
I completely agree with that. I think we both referred to the 25 to 50% chance that the diagnosis will be changed based on one or two of those evaluations. And just as you can imagine expertise developing in the ability to care for kidney cancer, you can certainly understand when you have a high volume of expertise in looking at kidney tumors on a CT scan or an MRI, or looking at pathology under a microscope, you develop a level of expertise that becomes very valuable. Very frequently in centers such as Cleveland Clinic, we will have frequent feedback where we will go back and evaluate. Now, we read these all this way. How did these patients actually do? And that feedback also refines the ability to really, make a very substantial contribution by having that 360-degree evaluation.
And just wanted to build on the point Chris made, because there's also the collaborative point. We take a very multidisciplinary approach. So with pathologists speaking to a medical oncologist, speaking to the surgeon, and we find, within the collaboration, we typically get better, I think more clarity and better options.
That's exactly what I was going to say. I think patients need to keep in mind that when it is, especially for the more complex cases, your doctor's not operating in a silo. They are asking the radiologist. They are asking the pathologist. You're talking together. Sometimes a clue from your clinical history can help with something that's a little more obscure on an ultrasound, sort of sorting that thing out. So these multidisciplinary teams are common, and I would think a 360 view would sort of be that best view as well. So I want to thank you guys both for joining us today. Frank for pinch hitting for Dr. Rasmussen. I think this is really great. And, especially for those people that you showed were in sort of that dead zone of NCI centers up in the sort of mountain area there, Montana and Utah. There's definitely some great centers in those places, but it may be farther for people to get to. And so having services like this and knowing that second opinion can be important is good for our patients. So thank you guys today. You guys are off the hook. Enjoy the rest of your Saturday. So thank you very much.
Thank you.